Okay, so I guess we can make a start. Hopefully people online can hear, but yeah, just send a message if you can't. Really delighted to have Siana with us today. So Siana and I met kind of only a few months ago, really, when I was in Oxford and Siana was presenting as part of Aidan Doherty's wearables group. And she's presenting some of the work that she's been doing, largely using data from ALSPAC, looking at physical activity, but also cardiac measures within the cohort. So, yeah, Siana could obviously tell you more about her background, but she's a physiologist specialising in activity and cardiac research, and she's a senior research fellow in the Institute of Cardiovascular Science. So yeah, Siana, thanks.
Cool. Thank you. Thank you so much, Becky. Hi. Yep, so I'm Siana and I'm from UCL. I work in Alan Hughes and Nish Chaturvedi's group in ICS at UCL. And I actually have got a little bit of history with ALSPAC. So I worked here as a field worker when I finished my MSc a while ago. And then I was involved in doing cardiac imaging at 17, not so much at 24. By that time, I'd gone over to London. So, but it did help with training the team. And I've been training the field workers who are doing the cardiac measures not at the moment, not anymore, but were doing it for focus study. So, cool. Okay, and the title of my presentation is actually the title of a fellowship that I've applied for. I've applied to the British Heart Foundation for some money to continue the work that we're doing with ACME. And I'm basically just going to talk you through that proposal today. And then if there's time, I'll talk about the background and the research aims and the methods. And then if there's time, I'd love to show you some pilot data that we have. So the big picture, physical activity, in particular exercise training, as we all know, is beneficial for our cardiovascular health. However, over half of children and adolescents in the UK do not achieve the guideline physical activity recommendations. And the long-term effects of physical activity throughout childhood and adolescence on adult health are not particularly well understood. And so my idea is that using longitudinal data, we could, and gaining a better understanding of the effects of, or understanding of these associations between childhood physical activity and adult cardiovascular health, could help us to develop new approaches for cost-effective physical activity interventions that can improve health. So the first research aim is to quantify how physical activity patterns in adolescence are associated with adult cardiovascular health in men and women. Okay. So a little bit on the current evidence that's available. There have been trajectories of physical activity explored in existing longitudinal studies, and that includes ALSPAC. So Raquel published some really nice work where she looked at trajectories of physical activity across 11, 13, and 15 in ALSPAC, and she looked at lung function outcomes. And then on the right of this slide, I've put some data that was presented in a paper showing results from the RAIN study. So this group, and just note that this is just the women here. There were men in that study, but I'm just showing the women. So this group looked at participation in sports through ages 5 to 17. And they found these three sort of key groups: people who always were participating in sport, those who did participate and then dropped out, and then those women who were never really participating. And the outcome that they chose to look at was something called peak VO2. So peak VO2 is a measure of fitness, but in healthy young adults, peak VO2 is determined by your capacity to augment cardiac output. So it's really a cardiovascular measure in healthy folk. And so unsurprisingly, this group showed that peak VO2 at age 28 was highest in those folk who were consistently participating in sport, and then lowest in the non-participators. And one of the big limitations of this study and quite a lot of other longitudinal studies is the use of self-reported physical activity data. So it can be subject to bias. It's not always people telling you exactly what they're doing. And it also limits our ability to explore the role of physical activity at different intensities. So that's quite important. So I mean, by that, I mean like light, moderate, vigorous intensity. How are those things individually associated with health? And another limitation actually is the use of traditional cardiovascular outcomes. So these can be, sometimes differences in these are not apparent in young or middle-aged adults. So for example, blood pressure, resting blood pressure, you might not get very much variance in that measure in young folk. However, in the RAIN study, one of the strengths was that they used the outcome peak VO2, which is a dynamic measure, so it's the response to exercise. So the next research aim of mine is to identify the relative importance of different intensities of physical activity on dynamic measures of cardiovascular health in adulthood. So I also want to explore the mechanisms of this association between physical activity and cardiovascular health. And I guess the question I'm asking is why might childhood behaviors be important for adult health? So you might just think it's all forming good habits. It's like if you're very active when you're young, then you're more likely to be very active when you're older. But there is actually evidence for, along with that, there being some biology underlying these associations. So there's really strong evidence that the origins of cardiovascular disease begin quite early in life. And you can see on the right here, I've put a schematic from a review, which shows cross-sections through an artery across different ages. So we've got, and it's really tiny, sorry, it's so tiny, but at the top here, we've got the first sort of decade of life, and then here we've got, can you see that? Hold on. And then here we've got sort of age 20, 30, and 40. And you can see even as young as 10 years old, you can see fatty streaks within the inside lining of the arteries. And so exposure to risk factors could lead to can lead also to adverse cardiovascular remodeling, which is partially irreversible. So for example, if you are a smoker or you have high blood pressure, even when you stop smoking or reduce your blood pressure, you still cause damage to your arteries, which is actually a little bit irreversible. And one plausible or presumed mechanism is that these risk factors might exacerbate elastin degradation. So vessel walls are made up of elastin and collagen. The elastin's the bit that is important for the compliance of the vessel. And the more compliant, the less stiff the arteries are, then the better that is for your health. So stiffer arteries are bad and more compliant arteries are good because they sort of control the transmission of the pulsatile energy into the small vessels. If you have more pulsatility transmitted into small vessels, then you get damage of those capillaries. So we're linking now large vessel function to, or linking the heart, large vessel function into the tissue. And so one thing that we don't know is whether you might have sustained positive remodeling or a mitigation of that degradation in elastin if you did physical activity when you were young. That's totally possible. So just to get a little deeper into the mechanisms, mitochondrial function has been linked to the circulatory system. So mitochondrial dysfunction is observed in the skeletal muscle of patients with cardiometabolic disease. So that's heart failure, peripheral arterial disease, even in type 2 diabetes and diabetic cardiomyopathy. And although we understand that these things go wrong at the same time, the cardiovascular function goes wrong and the mitochondrial dysfunction goes wrong, we don't really understand the relationship between mitochondria and the cardiovascular system in healthy adults. We do know that exercise training improves mitochondrial function within skeletal muscle, and also improves vascular function. And we don't know about the longevity of these effects, and we don't know about the role of physical activity at different intensities. So my next research aim is to identify whether youth and adult physical activity across different intensities are associated with skeletal muscle, mitochondrial, and cardiovascular function in adulthood. And I also want to describe associations between the mitochondrial functions, and there are lots of them, and cardiovascular function. So I should have said this at the beginning and I forgot, but just in case you've forgotten what mitochondria are, they're these little organelles. They hang out in the cytoplasm of cells, and they're really important for oxidative respiration. So that's ATP production and control of reactive oxygen species, which are important for oxidative stress, cell apoptosis and calcium handling, and there's a whole list of other things that they do. So they're super important and interesting organelles. Okay, and then my final background slide is around sex differences. So we know on average that girls participate less in physical activity than boys across all ages and in adults as well. But the current guidelines are the same for girls and boys. And really interestingly, there was a recent piece of epidemiology that suggested that women might enjoy equivalent health benefits for a lower quantity of physical activity compared to men. But we really don't understand the mechanisms of this, even though we know that women have higher capillary density and a greater proportion of these mitochondria-rich oxidative muscle fibers compared to men. And these different features of the muscle alter its metabolic as well as its contractile properties, and this could potentially contribute to a more favorable response. So then my final research aim is to establish whether there's sex-specific associations between physical activity and cardiovascular health, and that's macro and microvascular cardiovascular health, and or mitochondrial function. I'm just going to talk a little about the proposed methods for this, and some of them are already, some of the data is already existing. I felt like I didn't need to tell you what ALSPAC was. So I was going to skip this slide, but I thought I'd just remind you that physical activity was measured in the index participants using the hip-borne actigraph at 11, 13, 15, 17, and 24 years old. And we're currently measuring physical activity using an activity wristband in, I know it's not Focus 30 anymore, but it's in the Focus Focus 30. And this is a really neat device. The activity wristband device is 24 hours, so there will be information about sleep for people who are interested in sleep. Okay, and the ACME study, which you may be familiar with, this is a study, the aim of this was to embed dynamic cardiovascular measurements into ALSPAC Focus at 30. And the PI of these measurements that were embedded is Prof. Hughes at UCL. So the participants came in for Focus 30, as you know, and they undertook a cardiopulmonary exercise test, or a CPET for short. And the cardiovascular measures include peak VO2, which we've already talked about. This is measured using expired gas analysis. So you can see here you've got, this is one of your clinic team downstairs, all dressed up, practicing the exercise test. He's got a mask over his nose and mouth, which is capturing everything that's coming in and going out. Well, oxygen in, carbon dioxide out. That's how we measure peak VO2. And the exercise test is incremental, so you keep the cadence the same, and then you add load on the bike over the course of about 10 minutes. And once your participant can't do it anymore, can't keep the cadence the same, that's the end of the test. So the other things we did in this study, which are a little atypical of a CPET, a traditional CPET, is that we added a device that measures stroke volume. And so then we can calculate peak cardiac output directly from the heart. We did that using cardioimpedance or impedance cardiography. And then we've also got a little device that goes on the muscle to look at changes in microvascular blood flow and tissue oxygenation during exercise. And then obviously you have a whole load of traditional cardiometabolic outcomes captured at focus 30, like glycated hemoglobin, lipids, the resting blood pressure, central and peripheral, waist to hip ratio. And then there are a bunch of submaximal measures that we can take from the CPET as well. So it's a super rich data sets and really exciting. And so here we have some of the analyses that I planned that I put in my proposal. This is not my area of expertise at all. So these are just ideas and they're things that I've put in. It's not exhaustive. I'm sure there are loads of other ways of doing this. And I'm really interested to hear what you guys think as kind of more expert in that world. But I'm thinking initially a causal mediation analyses to directly test whether physical activity exposure at each age is associated with adult health outcomes, with a focus on the cardiovascular ones. And then inputting adult physical activity into that model as a potential mediator. And then also I've had a go at using structural equation modeling to consider the associations between physical activity at all the ages and each of the health outcomes. And I've had a thought, I haven't tried this, and probably I'm not sure if it would work, but to test different life course hypotheses using least angle regression. So I've only read about this, I haven't tried to do it, but this would be to test these hypotheses like accumulation. Is it accumulation of physical activity throughout childhood, adolescence, early adult life? Or are there potentially critical periods where it's really important for you to do activity or particular kinds of activity? Or is it all just recency? Is it just to do with what we're doing now? You know, does it matter what you did? Maybe it doesn't matter what you did. And I also really am keen to perform all these analyses in men and women together and separately. Yeah, and so these are my proposed new measurements for ALSPAC. What I'd like to do is invite a subgroup of participants to undertake detailed muscle measurements, so both in vivo and ex vivo. So the idea would be to invite 80 participants, 40 of whom had very low activity levels between 11 and 13, and 40 with very high levels of activity. The reason for the small number is just that these muscle measurements are really quite difficult to do. Like it's time consuming, and you would only really be able to see one participant a day. So it's not quite the same as turnover as you would get in the CPET. But I don't think we need to do too many people to have a look at the mechanisms to get some understanding of them. So we'd invite these folk back and do in vivo NIRS measurements. So using NIRS, you can look at reactive hyperemia. So you a little bit of ischemia, and then you release the cuff and you look at how well the blood vessels respond after the ischemia. You can also estimate oxidative capacity in vivo using NIRS. And then ex vivo, we would need to do a skeletal muscle tissue biopsy. And from the biopsy, you can do really fantastic stuff. So you can look at fiber type composition, you can look at capillary density, important vascular measure. You can look at mitochondrial content or volume. So that's like the number of mitochondria, although we don't talk about that too much. We talk more about the volume of mitochondria. And then also you can look at mitochondrial energetics. So how efficient are they at doing oxidative respiration using, for example, fatty acid as a fuel source or carbohydrate. And I put some pictures in case you guys weren't too familiar with skeletal muscle biopsies. So look away if you're a bit squeamish, but it's really a very minimal procedure. You use a general anesthetic, very tiny incision, about a centimeter long. It's quite a big needle, but you're not taking very much tissue. It's just a little tiny bit of tissue. And you can see we partition off the tissue and we freeze some of it, and then some of the analysis you have to do in fresh. muscle. So we put the tissue underneath the microscope, and then we create these little fiber bundles. They're really tiny. They're like 1 to 3 milligrams weight. And then we put the bundles go into a chamber. This is this picture at the end here, and it's a controlled chamber with a known concentration of oxygen. And then you add substrates to that will allow the tissue to respire using different complexes within the electron transport system. So it's really cool. You can really pick out what's going on in the tissue. And then obviously I'd want to compare the mitochondrial and the microvascular measures between the low and the high physical activity groups while accounting for physical activity in adulthood, and establish whether these measurements are associated with each other. So whether measures of mitochondrial function and skeletal muscle are associated with our cardiovascular structure and function measures, again, across the vascular tree. And again, I would want to perform these recruiting equal numbers of men and women, so to do the analyses together and separately. I just put a little break in here because I wasn't really sure how long you wanted me to talk for. So I've got some pilot data, or I can stop and do questions. What's the norm?
Did you mean general anaesthetic when you took the?
Did I say general? Oh no,
Yeah.
no,
I
local.
assumed you meant
Sorry,
local.
yeah.
I'm like, what?
Yeah, no. Sorry, yeah.
It's okay.
Yeah, it's just a little bit lidocaine.
I was wondering what proportion of people consent to that.
To do a biopsy?
Yeah, and whether you get that selection.
Out of ALSPAC, I don't know. I mean, I went to the participant, what do you call them? The committee that discussed. Yeah, the focus group. So I went to this, and there's there was one person who said, this is, going to have to pay me a lot of money from my muscle tissue. And then there were a few others who said, this is, yeah, I'll definitely do that. That sounds like fun. So yeah, I don't know, but it's a good question. And it is also a question that reviewers ask. So I said I submitted this VHF, I got reviewer comments, which I had to respond to. And they were really keen to know that as well. And so one piece of pilot data that I put in to the second round was to demonstrate the sort of feasibility that we could get people to come and agree to do this. So we did do a study just a couple of years ago looking at people with long COVID, and we managed to get healthy controls come in. So we had 10 people altogether, 5 with long COVID and 5 without. So a very small study, but we did manage to get some healthy volunteers.
Was that sort of 5 out of 5 approached, or did you have to, because that's what I'd want to know as a reviewer, did you have to approach 50 people to get 5 control participants?
Yeah, no, I don't think we had to approach that many. But the problem was we recruited from sort of staff and students at university, and that's, as you know, it's much easier. They sort of understand what's going on. They have an understanding. So the answer really is that I don't know, and I'm hoping. We're going to offer some incentive, and we're also going to offer travel costs and accommodation if people are willing to come to London. So.
Did you say how to get, was it 40 times 2?
Yeah.
Yeah.
So 80 people.
And was that, how did you determine that? Was it like, was it
just a power
calculation based on
my global measure of oxidative capacity for which I would do the non-invasive measure.
Because you're very interested in sex differences, did you,
yeah,
in terms of that power calculation, see what power you'd have to get a true interaction test suggested?
No, not for interactions. I mean, that's going to be a big limitation, but I did do the power calculation and then just doubled it so that I could run the analysis stratified. So I'd be able to look in men and women separately.
But the question really needs the interaction, not just you could get a picture of that but you wouldn't
Yeah.
want to be basing it on p-values within a subgroup.
Yeah, for sure. I'm not sure if you could possibly do that study. I mean, you'd have to have hundreds of people, so that, I guess, you're right, it'll just give us an idea.
Yeah, if there's marked differences, you'll be able to see it descriptively.
Yeah. So, I don't know, do you want me to talk about the pilot? Yeah, I mean, I think this is super exciting. This was, again, like, it was a really small study where we looked at fatty acid oxidation. And you can see here, we didn't find, so the P's are for the mean difference between the controls in black and the long COVID in red. And this is the important one here. So this is maximum oxidative respiration with fatty acids. So no differences overall, but you can see we've got this one pair. They were age and sex matched. This one matched pair that just did the opposite of everybody else. So, you know, I don't know. It's possible that there are some differences there in mitochondrial respiration. I think one of the really key things here is that none of these values are out with what would be considered normal. So there's no indication that this is a mitochondrial disease. I think we can put that to rest. Can't do anything with these numbers, but it doesn't really say there's mitochondrial disease. It just might suggest a detraining effect, would be within the limits of detraining. So yeah, really interesting. Lower fatty acid oxidation with long COVID. I've got some existing ALSPAC data as well that I've had a look at. So I had a little play about with the physical activity data that are available. And then we have cardiovascular health measures at 24. And so I've just demonstrated associations between physical activity in adolescence at 11, 13, and 15, and adult cardiovascular health at 24. I've included physical activity at 24 as a mediator. So important to note that I'm going to show you the results in a minute. It's just the table's pretty huge. So let's explain it first. So I've looked for just moderate to vigorous physical activity at each age. I'm not presenting here the total physical activity. And the outcomes, one of the outcomes, we've got resting and exercise blood pressure and body fat percent. One of the outcomes is an estimation of peak VO2. So this is based on the step test that they did at 24. So it's not a perfect measure of VO2. Okay, and I'll show you direct effects. So for example, at the bottom, the direct effects being the direct association between MVPA at 11 and estimated peak VO2, and then also indirect effects. So with putting MVPA at 24 into the model. I told you it was a big game. So here's our outcomes. We've got estimated peak VO2, resting blood pressure, exercise blood pressure, and body fat percent. And then our physical activity age, so 11, 13, 15. And then you have direct effect, the indirect effect, and the total effect. And at the far end, the very far side, the direct effect of MVPA at 24 in each model. And so the values here represent the change in each of these outcomes for a 10% increase in minutes of MVPA. And then in the purple column, the second from last, this is the total effect if participants would achieve guideline recommended MVPA, which is an hour a day MVPA. So, yeah, I guess what's kind of interesting to me here is you get this direct effect of physical activity at 13, or MVPA at 13, on our peak estimation of peak VO2 at 24, which is kind of interesting. They're quite small effect sizes, but I think quite important if you look in Biobank, for example. A 1 to 2 mil per kilo per minute of increase in VO2 can result in potentially reduction in cardiovascular disease of around 2%. So, interesting, I thought. Quite big effects. The positive values are increased, and then obviously the negative values suggest a reduction in blood pressure and body fat with physical activity. Sure, questions about this? I was feeling like I might get pushed back against this. I don't know.
Feels sort of to highlight one result out of so many.
Yeah.
Difficult to really interpret that. What I can't see from here, because my vision's not good enough, is do the results, are they telling a consistent story, or is this one that could just be either very interesting or just due to chance?
No, I think if you look also at sorry, you can't see it, but if you look at the other results, you do see independent effects from the physical activity in use on adult cardiovascular measures, and I think that's really interesting. And this is even with the adult measures in the model. So, you know, I think there's something going on there, and it's not just because physical activity tracks across ages. But like I said, I highlighted the limitations. It's only MVPA, and it's only and this is an estimation peak VO2, so I wouldn't. I'm not sure if I would write home about it just yet. I think that's pretty much it. I've got one more piece of pilot data, which is it says again muscle biopsy. This was just really to demonstrate an association between the mitochondrial measures and the vascular measures, and it's work that I did as part of a travel fellowship. I went over to Orlando. There's a lab over there where they do these biopsies all the time. They do a lot of them, and that was where I learned how to do the processing. And they also allowed me to embed some vascular measures into a bed rest study that they were doing. So this is where you put someone to bed for 10 days. And yeah, they pay them a lot of money in America to do these things. So yeah, and this is actually just four participants, but they have multiple measurements. So they have a biopsy on day 1, day 3, day 5, and day 10.
Wow.
Yeah. And then we did these vascular measures on the same days. And then the graph in panel A, so the first one is the oxidative phosphorylation on the X. So that's my mitochondrial measure of respiration. And then on the Y, this is time to post-occlusive reactive hyperemia, which is a measure of vascular reactivity, vasodilatory capacity. And so it's a negative slope, because the longer it takes you to react to that ischemic stimulus, the poorer your health is. So, and the lower your oxphos, then the poorer your respiration. So it is, no, it's negative, but it is saying the same thing. That's highlighting that these measurements are related to each other. Better oxphos, more rapid reactive hyperemia. And then again, so each dot is one measure, if you like, and there are clusters around each participant. And then in B, although there's only 4 participants, so this is super preliminary, but I looked at the oxphos across the 10 days, and then I looked at the reactive hyperemia across the 10 days. And you see this nice, with the wide confidence intervals, these reduction in oxphos along with an increase in the reactive hyperemia. So really lining up these 2 measurements, suggesting that they probably potentially depend on one another.
Have there been any sort of long-term training studies which have done the peak measures and actually shown reliable changes?
Yeah, absolutely. So mitochondrial function improves with, or respiration improves with training, and in veteran athletes as well, you get really much higher rates of respiration and better fatty acid oxidation in athletes than you do in sort of healthy age match controls. But nobody's really looked at, for example, capillary density or any of these reactive measurements. So I think that's something that's missing and could be really interesting. And again, not so much in the healthy folk, like a lot of veteran athlete studies or people in different conditions. Cool. Thank you very much.
Really interesting study. Yeah.
I think that's me done. Finally. Sorry.